So I would say in pancreatic cancer per se, as we discussed, this is not a very rare mutation. It's still present in 15 to 20% of cases of our patient. And as a pancreatic oncologist, because I see just pancreatic cancer, we do encounter these patients. But for sure, looking at this and other rare alterations, what is very crucial in finding and being able to direct this patient to the right treatment is a universal and early genomic profiling. In other words, if we don't look for these mutations, we would not find them, and these patients can lose their potential to get better or theoretically less toxic targeted therapies. For sure, again, in a situation, specifically if the alteration is rare, even more than what we had, there are other ways to try and we utilize some of these. We can use like patient-oriented groups such as PanCAS, Magowies to provide the patients with the opportunity to understand the availability of this study. We can use the platforms or vendors that do the genomic profiling to work with them to identify this patient through the profiling that they do regionally and even nationwide. And there has been very successful studies done by the cooperative groups such as Alliance, ECOG, and such, that they can nationally try to identify patients and enroll. So I think these are all measures that can be utilized to try to make studies of rare alterations successful. We know some players in the MAP kinase and the RAS activation pathway. We know that mutated KRAS and its interaction with the wild type RAS and the percentage of the how much the MAP kinase is driven by each is important. We know that EGFR expression and possibility of activating the wild type RAS, irrespective or independent of the mutated RAS, is important. So what we are trying to do is trying to really be a bit more specific and be a bit more precise in trying to identify which exactly are the dynamics of this pathway in each patient, trying to identify what would be the best potential treatment for that patient, not just by the bulk sequencing, but by other like expanding like the biopsies into organoid models or such, which will allow us to study the dynamics better, expose them to different drugs, try to identify the best combination treatments. And I would say a very important portion will be, as our targeted therapies improve, how can we potentially utilize MEK inhibitor with other targeted therapies? How can we understand the other pathways that are active? And again, like our attempt here, can we identify better combinations, not just focusing on MAP kinase and other pathways with the MEK inhibitor? And of course, it will be very important to follow this patient, identify mechanisms of resistance, so that we can see whether from the get-go, we could have done something to delay or prevent this acquired resistance. And whether, even if that acquired resistance happens, can we make any adjustment in the treatment to be able to continue some components of the treatment, but just add another drug that can overcome the newly acquired alteration. I think this is a very interesting area for the KRAS alteration. Very understudied because, again, it's really rare in other cancers. It's much more frequent in pancreatic cancer. And also, I would say it's a bit of a challenge in targeted therapies in the cancers. One approach is to treat and see whether it responds, and then if it doesn't, go and learn from failures. The alternative is to really know better the biology so that when we are going to treat, we make smarter choices. So I think our hope is to be the portion for sure combination, but also try to really understand the biology better. Knowing the biology of the MAP kinase, it's not just important for the KRAS G12R, it's important for other KRASs, it's important for newer KRAS inhibitors. So I think our hope is that not only MEK inhibitors would be important in this, our knowledge of these pathways will really guide us with newer KRAS inhibitors and such.